right, I think we're ready to start. Thanks very much, everyone, for coming here the day before the conference fully starts. So, very grateful for your interest and your attention. Especially grateful to those from our caregiver and patient support and families. I met some of the young people earlier. It was great energy in the room. They're going to all come back a little bit later, all the kids, and you're so welcome. And it's going to make this a very memorable and special session in the IEC history. Just on a little housekeeping note, if you scan the QR code, you'll get the full program. For those of you who don't have one, you get speaker biographies and so on that you can download, and it'll help you follow it a little bit. So it's an exciting scientific and also a personal journey story today that we're going to hear those testimonies. And the title of our story today is Converging Pathways, Atopic Dermatitis and Alopecia Areata. This session is going to be recorded and it will be on demand on the IEC website and on our YouTube channel. Any questions, there's some emails to Alan Stiles. If you want to join the IEC or any other questions, here we go. I'm going to very briefly tell you a little bit about the IEC. This is our 10th anniversary. The IEC was founded by Emma and by Amy, who will be along with us shortly and who's also speaking. And in those 10 years, we've grown a lot. We've been very engaged in developing and supporting new therapies, new treatments, new guidelines, new pathways for patients living with atopic dermatitis. We've now expanded to counsellors in 33 countries. We have 151 counsellors and 151 counsellors and associates as well. This is our global representation from all around the world. We're constantly wanting to expand that. If you're interested, let us know. If you know PhDs who are interested, let us know also about PhDs. We started taking PhDs last year. And also in 2023, we expanded our criteria to take allergists. So I know some of you were at the meeting. Some of the patient groups were saying they met us at the Quad AI meeting, which is another important meeting in our calendar where we interact with the allergy community and people living with allergies. So again, anyone who knows of anyone in this category who's interested, please let us know. The IEC has broadened our scope. So we have a mission to improve patient care by promoting research, education, and best practices in AD. Our vision is to transform the lives of people with atopic dermatitis, and it's been amazing to see that transformation. You're going to hear about it later today, but just to see that over the last 10 years. We're a global community of leaders in AD research, treatment, and prevention, and our values are patient-centered, and we're going to see that today. Innovative, evidence-based. We want to be globally inclusive, collaborative, and forward-looking. We're supported by a lot of industry support, and we're really grateful to that. This is the only way we can deliver our mission and fulfill our vision is with the support that we have, and we've been well supported, and we're really grateful for that. We run 5 or 6 symposia a year. I mentioned earlier we've been in the Quad AI, and today is a very exciting one, which you're all going to see very shortly. We'll also be in Argentina for the World Congress, in San Diego again for the Society of Investigative Dermatology, and in Europe for the EADV. You can find and connect us. We've got 4 social media platforms, whichever is your favorite one to engage with. Just a shout out for our YouTube Learning Centre. YouTube Centre, we've had more than 10,000 views of our material there. Today's session will find its way there shortly, so you'll be able to watch back anything that you may have missed or wanted some additional information on. Any questions, contact Alan Stiles. This is the scan that we saw earlier to access the program guide. Everyone's got it. And this is our agenda for today. So I'm going to just introduce our 2 chairs, and we're really delighted with the faculty that we have and the time that they've put into this along with the patient organisations. It's superb. I don't think Emma really needs introduction, but she deserves it, so we'll give her one. So Emma's the Assistant Chair of the Department of Dermatology and the Waldman Professor of Dermatology in Sinai. I think everyone knows her accomplishments. She's the Director of the Centre of Excellence in Eczema and the Laboratory for Inflammatory Skin Diseases. Her major research focuses are very like today, atopic derm and alopecia areata. She's made paradigm-shifting discoveries, influenced drugs that have made lives to change the lives of hundreds of thousands of people at this stage. I mentioned earlier her co-founder status for this society, and she's published so many influential papers. So we're delighted to have Emma as part of our community and here today. And our second chair is Natasha Mezinkowska. She's a prolific writer, teacher, and researcher. She's a Mayo Clinic and Cleveland trained dermatologist and Dermpath, who serves as the vice chair of clinical research in the Department of Dermatology at the University of California, Irvine, California. She's busy clinically, dedicated to to alopecia, aging, and inflammatory disorders. She's the director for integrative dermatology. You'll be hearing more about that later today as well at the Susan Samueli Integrative Health Institute, advancing evidence-based research in this arena. So thank you very much for being with us. I'm going to hand over now to our co-chairs who are going to give a little program overview, and I hope you all enjoy today. Thank you.
She told me to do it. Okay, thank you so much. All right. So here's what we're doing today. We're trying to kind of establish the narrative that atopic dermatitis and alopecia areata have a lot in common. Genotypically, phenotypically, it is the most common comorbidity we see in alopecia areata. So all the talks that you hear today are going to try to give you that aspect, that angle, because I think ultimately we want to know what causes conditions in our patients and how we can prevent and then treat adequately and appropriately. We're going to start off the whole program with Dr. Gutman, who is going to tell us about the similarities and differences. Then Dr. Benjamin Unger is going to continue to tell us about the epidemiology. We're going to hear from Peter Leo about new developments. Then I'm going to tell you about new treatments. Amy Peller is going to give us the PEDS perspective. Then we're going to hear from Nia and Naf, and my favorite part, the patients when they get on stage. So that's what we have for today, and I'm super excited. Okay, here we go, Dr. Emma Gutman. I was looking up something, a figure on alopecia areata and atopic derm, and you came up with a photo and it said something about not believing in glass ceilings. And I will tell you that you've meant so much to me, to all the, I guess, doctors in dermatology as we come up. So I think you've kind of blazed the trail that nobody has. So thank you. Come on up.
Just bear with me. Yeah, there it is. So first of all, thank you, Natasha. Natasha needs to leave for 20 minutes and will come back. And thanks for this introduction. I'm not sure I deserve it, but regardless, thank you. So I like to think that I got interested in alopecia areata a little bit through the back door. Those of you that know me know I'm very passionate about atopic dermatitis. That was the main focus of my research for years. But I saw through actually some of my patients, and we learned from our patients that actually atopic dermatitis and alopecia areata are really connected, and that connection can actually benefit new treatments for alopecia areata, and let's learn a little bit more about that. And I'm super excited about this co-symposium that the IEC organized together with the National Alopecia Areata Foundation and the National Eczema Association and with patients. And I'm very excited. All the patients here are coming from Mount Sinai, either my patients or Dr. Unger's patients. So you'll have a chance to hear from many patients, adults and children. And I think the patient voice is really important, and I think it's the most convincing here. My disclosures, I have support from multiple companies, and none of them, I don't have currently ownership or financial gain from any drug at this point. So alopecia areata is a disease that many of us treat as clinicians, but for many years we didn't know that it's actually a quite prevalent disease because these patients, many of them didn't seek help. but it is very prevalent, about 2% lifetime prevalence. And in the United States, we are talking about 6.6 millions, almost 150 millions worldwide, so huge prevalence. Not exactly like atopic dermatitis, but like psoriasis. And usually affects the scalp, but can affect any hairy areas. And up to 20%, that's a huge number, will progress to total scalp, alopecia totalis, or total body hair loss, alopecia universalis. And I don't need to tell you that alopecia areata really causes tremendous emotional and psychosocial distress, not only to patients, but the entire families. And you'll hear today about some of this distress. Now, we need to remember that treatments are really lacking for patients with alopecia areata. For many years, we had the same old injections of steroids, DPCP that I myself do not like it. It's very messy. It works in a limited fashion. Patients don't like it. It's very painful. You need to repeat it many times. And many other treatments have immune suppressant effects like cyclosporine, oral prednisone. You cannot keep patients forever on these treatments. So for many years, there was nothing there. And still, we have a huge unmet need that still exists for safe and effective treatments. And I think the emphasis is for long-term disease control. Because yes, we now have treatments that grow hair in patients, but are we able to give these for 50 years or 30 years? Because patients need these treatments all the time, at least for now, right? Because we know when you stop these treatments, they shed their hair. So I'm not sure about that. Now, what is the pathogenesis of alopecia areata? So first of all, we know that alopecia areata is characterized by this infiltrate of T cells with different flavors of T cells, both CD4 and CD8. For many years, we thought that CD8 are the only game in town. Now we believe actually it's more CD4, but also CD8 play a role. And they attack the hair follicles. And pay attention that the attack of the hair follicles is very low. It's not like in scarring alopecia where it's much, much higher and then maybe you can treat with a topical. Here, it's very hard, if not impossible, to treat with a topical because that attack happens really very low. Now, going into the literature, it seems that there are many cells related to atopy that are also heavily involved in alopecia areata, and that was missed before our contributions, Mount Sinai's contribution to the pathogenesis of alopecia areata. So pay attention that many patients have eosinophils and mast cells. In fact, most of the cases will have mast cells, and many of the cases will have eosinophils in patients with alopecia areata, but people simply miss that association. Now, we know for many years from case reports, case series, and personal experience that JAK inhibitors work in patients with alopecia areata. They are effective. But we need to remember that JAK inhibitors are targeting multiple immune pathways. They are not specific to one single immune pathway, and they cannot really tease out the pathogenesis of alopecia areata. We need really to have specific targets to be able to tease that pathogenesis, and I think it's coming. And these are all being targeted by some of the JAK inhibitors. So again, you cannot tease out the pathogenesis. Now, what got me interested in alopecia areata was during the phase 2 dupilumab study, by chance, or maybe not by chance, because you heard alopecia areata and atopic dermatitis are highly epidemiologically associated, and I'll show you some data. But several of our patients in the dupilumab study, I think we put more than 20 patients in that phase 2 study, several of them also had alopecia areata, like this African-American patient of ours. And she had only patchy alopecia, several patches, but lo and behold, she grew all her hair back on a dupilumab, and these are patches that she had for a while, so it's not these type of patches that come and go. So I was scratching my head at the time because alopecia areata was considered at the time to be only Th1 driven. And like I tell my mentees, never accept dogmas, and particularly dogmas that come from mouse models. This dogma came only from mouse models, and we've proven it incorrect. And why is that? So when you look into the epidemiological data, and now there is a lot of epidemiological data, but at the time there was a very important study done by Abrar Qureshi from the time he was at Harvard, and it included about 3,000 and something patients. So a very large study, and he associated atopy in general and eczema in particular as the highest comorbidity of alopecia areata, and then a larger GWAS study, in fact also the largest study done so far, associated IL-13 as the highest association in terms of GWAS with alopecia areata, and then a very big study done in Israel in a lot of patients from an HMO showed that with each atopic condition you increase the risk to develop alopecia areata. And then also, we know that historically alopecia areata was considered a type 1 disease, and that the type 2 diseases are asthma, eosinophilic esophagitis, atopic dermatitis, allergic conjunctivitis, and urticaria. We know that these have high IgE, but lo and behold, and this was also missed, alopecia areata for quite some time, people were actually publishing that patients with alopecia areata actually have high IgE. Not only that, even those that do not have high IgE, they have increases in specific IgEs like pudasmide and others. And for many years we know, and there are publications out there, but we didn't ask why, that antihistamines are actually actively used in alopecia areata as an adjuvant, particularly to treat flares, and we know that the alopecia areata flares are associated with seasonality. So somebody needed to put all of this together, but that's why I love being a physician scientist, because sometimes it's important to take some ideas from the clinic to the lab and vice versa. And again, this brought me to a look into what cells are in alopecia areata. And after that, we did a huge study together with Benjamin Unger. In 1 month, literally, we enrolled 27 patients with alopecia areata without atopic dermatitis. But what we did, we compared 2 atopic dermatitis patients and 2 patients with psoriasis. And what we discovered is that all of these diseases will have increases in type 1 immunity that we associated with the chronicity of the disease, but only atopic dermatitis and alopecia areata have increases in Th2 axis, such as IL-13 and many chemokines associated with that pathway. And of course, patients with alopecia areata have decreases in hair keratins. These are very good biomarkers of the disease. So another important consideration for you to know that alopecia areata is not one size fits all. It's a highly heterogeneous disease, perhaps like atopic dermatitis. It has multiple flavors depending on the phenotype, such as alopecia universalis, totalis, patients with patchy alopecia, the ones with atopy, and so on. And we and others showed that these phenotypes may have some differences, like the ones that have atopy have more Th2, and the ones with psychosocial comorbidities have increases in IL-17, for example. Those with chronic disease, after a while, when you have really chronic disease, nothing happening, you actually have increased Th1. So alopecia areata will have different immune pathways. Th1 certainly is involved, but it's not the only game in town. The Th2 axis is involved in all patients, but more in those that have atopy. And it's important to remember. Another important consideration for patients with alopecia areata that has actually implications to how we treat patients is that even though these patients do not have redness, right, they only have hair loss, but they have systemic immune activation. So in patients with moderate to severe alopecia areata, when they have more than 30% of the scalp involved, usually this will be reflected in systemic immune activation. And we were surprised to find that that systemic immune activation is actually even higher than what you find in atopic dermatitis and psoriasis, right? It's counterintuitive. But that was the case, and this is in blood using Olink proteomics, and even cardiovascular and atherosclerosis were high in their circulation, not only Th1, Th2, and IL-23. And if we add that to now a cardiac morbidity being described in patients with alopecia areata, increased cardiac troponin, increased depressions, we understand that we need to treat these patients early before we are getting to those manifestations. So this, and you'll hear much more about new treatments coming into alopecia areata. This is the alopecia areata systemic treatment landscape, and it's expanding. We have several approved JAK inhibitors. We now have several biologics coming into the space, including several targeting Th2, but not only, and our own investigator-initiated study that you'll hear a little bit more about. And importantly, several clinical trials failed with topicals. And I still remember one of the companies doing a topical study came to talk to me, and I said, listen, you will not be able to be successful because the follicles, the attack on the follicle is really down below. But they said that people doing mouse work told them that 100% it will work, and multiple $1 million later they failed. So again, human and mice are different. You cannot take data from mice and extrapolate to human. Now, I want to show you the study with ritalcitinib that now is approved for patients with alopecia, Litfulo. It targets several cytokines, but pay attention that many of them are actually part of the Th2 pathway, if you look carefully, because it targets JAK3. And this is the clinical data, and this is the biomarker data. My lab did a mechanistic analysis, and I want to show you that the improvement was associated with reduction in Th1, as you expect, but also reductions in Th2 and in IL-23, and of course, increases in hair keratins. Now, when we associated the clinical hair regrowth by SALT with biomarkers, pay attention that at both week 12 and week 24, you have high correlations with the Th2 biomarkers, including IL-13, CCL17, right, the hallmark biomarker of type 2 immunity, and CCL18 as well for week 12. So Th2 biomarkers are highly associated with the improvement in diseases. Now, all of this led to our initial study with dupilumab in patients with alopecia areata. That was a small study, 60 patients, 40 started on drug, 20 started on placebo. We did weekly dupilumab, and that study was only adults, and we did not focus on any specific population. But we found that the patients that had either high IgE or had atopy, either eczema, asthma, or any atopy, either themselves or in the family, these were the ones that responded better. It's not that the other ones did not respond, but they responded slower and not as well. And we did also a biomarker study for the same study. And I know that heat maps sometimes get us to be a little bit blurry. I'll walk you through this. Just think about the fact that red is immune activation, blue is downregulation. You clearly see that in the dupilumab arm, you see changes, right? Red turns into blue, and at some point, the lesional scalp looks like non-lesional scalp. And you don't see that with the placebo arm. We only had placebo up to week 24. Now, we wanted to quantify the genomic profile or the improvement in the genomic profile with dupilumab, and pay attention that 98% of the phenotype was reversed by week 48, only in the dupilumab arm. And also you see improvement in the hair keratins. And when we wanted to see what is the improvement by immune pathway, pay attention that at 24 weeks, we only had improvement in the Th2 pathway. The Th1 pathway did not move because it's not a direct target of dupilumab. That only moved at 48 weeks. Lo and behold, the hair keratins that are very good biomarkers because you have to see them increase, they already increased at week 24, even before we saw that clinical improvement. What does it tell us? I think that proves the idea that Th2 is an early important event in alopecia areata, whereas Th1 is important for perpetuating the disease chronicity of alopecia areata. And you do not need to believe me, but you need to believe patients. These are some of the pictures from the study. Now, I want to say that all of these patients are still on this drug to this date. And these are some of the improvements. They since all gained all their hair back because it takes time. There was continuous improvement even after the secondary endpoint. And one of the patients, you'll meet her here. This is from her Instagram post that I allowed myself to take, but you'll hear her story here. She's actually on the second study we are doing now. In this study, we are honing into the population we think it will work better, those with atopy and high IgE, as you might have guessed. And she'll tell you her story herself. And we are very excited. We are doing now, together with some of the people here, with Amy Paller, Natasha, we are doing an NIH study that Sinai is the central site, in which we are treating children with alopecia areata, with atopy, and or high IgE. And this is based on data that we have on a large subset of children that had also atopic dermatitis, and we could give them a dupilumab, such as this child. And this is another child on dupilumab, and she wanted to document her journey. And here I also see how I lost weight, because in the middle, as you can see, I gained weight during the pandemic, but you can see how she gained all her hair back. It was a long journey. It took about 14 months. So I always say dupilumab is a marathon runner, but it's better safe than sorry. Amazing safety, and it does work, particularly for that population. So I hope I convinced you that alopecia areata is joining the atopic march, similar to other diseases such as atopic dermatitis, seasonal allergies, asthma, urticaria, and others. So to conclude here, we know that alopecia areata is a highly inflammatory systemic disease with emerging pathogenic roles, not only for Th1, but also Th2 cytokine circuits, and significant downregulation of hair keratins. And I think it may present a similar model to atopic dermatitis, where the cytokines, instead of suppressing the barrier formation, here they are suppressing the formation of hair keratins. And it's reversible. And evidence is mounting that alopecia areata is belonging to the atopic or allergic spectrum, and the increasing understanding of pathomechanisms of alopecia areata, I think, is key for us to be able to develop new treatments for alopecia areata. So with that, from my department and many people from my department that are here that really are part of this miracle, and we are very invested now in changing many lives of alopecia areata patients that literally come from all over the globe, not only the United States. So from all of us, thank you. And now it's my distinct pleasure to invite Benjamin Unger, also from Mount Sinai. He's the director of the Alopecia Center at Mount Sinai, and he's been working with me for many years, in fact, since he was a student at Mount Sinai. And I'm very proud of him to give the next talk on comorbidities associated with alopecia areata.
It says BU, right?
Yeah. Okay. All right. Thank you very much. Good afternoon, everyone. It's my pleasure to discuss the epidemiology of alopecia areata, and in particular the atopic comorbidities. Hopefully, by the time we finish this talk, you will be firmly convinced that there is a very strong link between alopecia areata and various atopic conditions. Here are my disclosures. So just, again, in brief, we're going to heard some of this already, going to hear more about alopecia areata, but it is an autoimmune disease where there is disruption of the hair follicle. It's the most common cause of inflammatory hair loss, and there is that unpredictability in terms of the course. Many people have relatively limited involvement. It can progress, as Dr. Gumman mentioned, to full body and scalp hair loss in many cases. It probably can't be overstated how much emotional and psychosocial distress is associated with this condition. and really is one of the many reasons this really deserves and necessitates effective treatments. There's a wide variety of clinical presentations, but I'm going to focus on the epidemiology. And you'll see a number of slides that look at many different studies evaluating the link between alopecia areata and various comorbidities. I always like to take a moment to say that epidemiology can be a little challenging because there's often methodologic limitations in terms of diagnoses being made appropriately. The kinds of available databases make a difference, and the type of study, whether it's kind of a retrospective view at one center, a population-based cohort study. And so it's hard to put too much stock into one individual study because there may be limitations and flaws. But when you have many different studies that look at an association and show the same trend in various different methods, different populations, it really builds the case, I think, very strongly that there is this link. And even if the specific odds ratios and so on vary, that it exists. So with that in mind, there have been a number of studies done all over the world, different populations, and there's a lot of variability, and I'm going to go through some of that. Now, across the board, it is widely considered that there's approximately this 2% or so lifetime risk for alopecia areata, and the point prevalence, incidence, those change again or vary depending on the study, but that 2% mark, roughly speaking, seems to be pretty much the case. Its onset is most commonly seen in the third and fourth decades of life. Median age, again, depending on the studies, 20s to 30s, and the range of presentation can definitely vary in different areas. There, I would say, is kind of variable results on whether there's a gender bias. In some studies, females are more likely, in some studies, males. One of the points I just want to highlight that shows one of the challenges is that very often diagnostic and cultural practices can make a difference. This one of these studies done in Turkey noted that there may be underdiagnosis due to religious practices like head coverings that may miss some diagnosis. So, all this needs to be taken with a grain of salt on an individual basis. I would say overall, the studies tend to demonstrate a trend towards higher rates being seen in non-white individuals. In this study, in particular, using the National Alopecia Areata Registry, there was increased rates in African Americans. In this particular study, lower rates in Asians, but in other studies, for example, one in the UK, there's a greater incidence in Asian people. Black women more likely than white women to be diagnosed with alopecia areata, Hispanic women more than non-Hispanic women. This was a kind of a pooled incidence across a number of different studies, and again, we're pointing out that 1.7 to 2% overall, but we see here in some studies as high as 5%. And I think at the end of the day, the takeaway here is that it is quite common. This is not a rare disease. It's not something that is seen only once in a while. It's quite common. Beyond that, the prevalence does seem to be increasing as well. So this was one study looking across different ages, but over the last several years, there is this trend towards increasing rates of alopecia areata among children as well as among adults. And when we look at the most severe variants, alopecia totalis and universalis, again, there is that increasing trend in both women and men, children, adults. Again, this is increasing. The prevalence and incidence in pediatric alopecia areata, again, is somewhere in the, let's call it about up to 1%, peak age around 9 years of age. Again, depending on the study, you may see it a little earlier as well, which is really to say that it is common in children also. Although most commonly presents in, kind of younger adulthood, it's quite common in children as well. The trend towards seeing increased rates in non-white individuals holds true in the pediatric population as well. Okay, so more to the point of the topic of this discussion, which is a link with atopic disease, is that in the pediatric population, and we're going to discuss adults in a moment, AD was reported as the most common comorbidity. In this particular study, odds ratio of almost 10 times. There are other associations as well. So this is not to say that alopecia areata is only associated with atopic comorbidities, things like thyroid disease, vitiligo, other autoimmune diseases. But overall, by far the most common is atopic disease. And in many cases, perhaps even most cases, alopecia areata is the initial presenting autoimmune or autoinflammatory condition, with these other conditions subsequently being diagnosed. So again, this is a non-exhaustive list of some of the comorbidities and risk factors for alopecia areata: atopic disease, vitiligo, thyroid disease, smoking, sleeping disorders, environmental potential inputs as well. Now, with that said, atopic disease, and Dr. Gutman began speaking about this, I'm going to elaborate some more here, is again clearly the most common risk factor for alopecia areata and the most prevalent comorbidity. So somewhere, depending again on the study, AD, asthma, hay fever combined to up to 60% of patients with alopecia areata. And of those, in particular, atopic dermatitis has been the most clearly defined as both comorbidity and risk factor. People with even a family history of AD, more significantly likely to have more severe alopecia areata. So not only is it associated and a risk factor for alopecia areata, but particularly a risk factor for more severe variants of alopecia areata as well. And as I'll show in some of the studies as well, it makes it more likely that people will have alopecia areata presenting earlier in life as well. So we saw some of the evidence for the atopic inputs into the disease: Th2 pathway cytokines, elevated IgE, increased expression in both blood and skin of patients with alopecia areata for a number of these type 2 inflammatory cytokines. And we also see the efficacy of type 2 targeting treatment like dupilumab. There is also a genetic link between atopic dermatitis and alopecia areata. So Dr. Gutman mentioned the largest GWAS, genome-wide association study that identified IL-13 as a gene most associated with alopecia areata. We did an analysis, I think like 2 years ago, looking at the genetic relationship between AD and alopecia areata using Mendelian randomization, which is a technique to isolate the influence of the genetic background in one disease, essentially causing or influencing the other one. And perhaps not surprisingly, one of the genes that most influenced that association was IL-13. And in general, this whole suite of genes that were associated with atopic dermatitis was causally influencing the development of alopecia areata. And what that means essentially is that having these genes and AD kind of leads to some development of alopecia areata, where it does not in someone who has the same gene variants but no atopic dermatitis. Now I'm going to go relatively rapid fire through a number of studies looking at various odds ratios and hazards ratios of atopic disease. So here was one study in Taiwan showing a hazard ratio of 6, so quite a bit more AD. This was a study looking at female U.S. registered nurses showing an odds ratio of 1.8. Again, meta-analyses looking at this, combining various studies, hammer in and hone in on the point that there is this increased risk as well. There was one study in Denmark that showed an adjusted odds ratio of 26 times more AD in alopecia areata patients. So that's certainly an upper bound that is a bit of an outlier, but shows potentially the magnitude of just how much more likely AD is in alopecia areata patients. This was a study that actually looked at patients kind of on an individual basis. Again, almost 50% atopic. The age of onset of alopecia areata was earlier in people with atopic disease than non-atopic disease. This was another retrospective review, again, showing not only the very high prevalence of concomitant atopic disease, but also atopic patients having more severe disease in this case. So again, similar trends, prevalence 40, 50%, very, very common to have AD, allergic rhinitis, asthma, and so on. So I'll just kind of not belabor the point with those. This was one study, again, the one that I referenced before in the Taiwanese population, that really shows how people with AD are at increased risk of developing alopecia areata. So this is over 40,000 people, and the red line is showing the alopecia areata free probability, meaning the lower it goes, the more alopecia areata patients get. And there was, again, 6-fold higher risk of alopecia areata in people with AD. In this study, sorry, excuse me, there we go, nope, clicking incorrectly. In this study, there was actually the reverse association as well. So in 12,000 people with alopecia areata, there was an increased risk of subsequently developing atopic dermatitis as well. Again, almost approaching 6-fold risk. So there is this bidirectional association where having AD puts you at increased risk of alopecia areata and vice versa. It's not an individual study showing this. This was another study in the UK, again, comparing people with alopecia areata and not demonstrating the increased risk. This is a little confusing because now the graphs are going up instead of down, but increased risk in red for the development of AD. One study in Japan, again, looking at a whole suite of different comorbidities, over 60,000 people. You'll see that a number of different comorbidities are listed, but it's very clear from afar which graphs are the highest. And perhaps not surprisingly, it's atopic dermatitis, asthma, and allergic rhinitis. And even more so in the most severe alopecia areata subtypes, those associations are even clearer. So by far the most common conditions are atopic. Alopecia areata flares are seasonal. So this was one study looking at alopecia areata, and you can kind of see this trend, relatively small study, but people are flaring around the time of seasonal allergies. And then even people without clear-cut atopic background, which is in orange, you see that trend as well. So it's not just people with overt allergic rhinitis and they're developing, this is kind of across the board. We looked at this, published this last year, looking at having seasonal and or food allergies. What's the risk of developing alopecia areata? And we can see here that people with this history of allergy were 1.5 times more likely to develop alopecia areata, almost twice as likely to develop severe alopecia areata, and having both food and seasonal allergies increase that risk even further. Again, showing that this atopic background, it's not just limited to AD, although that's the kind of most commonly and most strongly reported association, puts people at risk for the development of alopecia areata. This is another study we looked at, kind of expanding beyond, AD, and this was in a U.S. database, and we see again allergic conjunctivitis increase odds, allergic contact dermatitis, which is variably reported but clear-cut increase rates here. Having at least one allergic condition, again, much higher odds. 2 allergic conditions, increased odds. And having multiple allergic comorbidities, people with alopecia areata were much more likely to have multiple allergic comorbidities. I mean, we know that atopic diseases go hand in hand very often, and having alopecia areata in some respects ties that together or strengthens the association of this atopic background. The most severe types of AA, universalis, totalis, again, much more likely with people with an atopic background as well. I mentioned before, a few times that having atopic disease is a risk factor for earlier AA. So this was one study recently published in Europe showing, here's a kind of just alopecia areata, no atopic or autoimmune comorbidities, mean age of around 30 years of onset. Start looking at the people with at least one atopic comorbidity, that age goes down a lot. So 25 years for one comorbidity, all the way down to 20 years of age, mean onset, when there are 3 or more comorbidities. So having more of this allergic background associated with earlier onset of AA. Alopecia areata is also a risk factor in the offspring of someone who has alopecia areata. So this was one study from Korea looking at people with alopecia areata, mothers, and found, not surprisingly, that offsprings were at higher risk of both alopecia areata and alopecia totalis, but again, a clear, very strong association with increased risk of atopic dermatitis, allergic rhinitis, and asthma as well. So with all that said, in summary, there's quite a bit of epidemiologic data from many places around the world showing the link, showing, I should say, different prevalence and incidence, but that this is a prevalent disease with a lifetime risk of approximately 2%. The onset is in the 20s and 30s, but as we saw, there are certain risk factors, primarily atopic, that is associated with earlier onset and more severe disease as well. So with that, I would like to thank you for your attention. I'm not sure if we're taking questions or happy to, or pass along the mic. So.
So the next speaker doesn't need much introduction. My very good friend that actually is also an adjunct physician at Mount Sinai. We are very happy about that. Peter Leo, that has done a really groundbreaking work in atopic dermatitis, and now branching also to alopecia areata. He's very interested about quality of life and integrative studies, as you know. And we are very pleased to have him here talk to us about alopecia areata.
Thank you. Thank you so much. Well, Dr. Gutman and Dr. Ungar did an amazing job, so maybe my piece will be somewhat overlapping, but I'll try to add a little bit of philosophy and maybe digest it a little bit for us, because I'm really not a scientist. I am mostly a clinician, and to hear all of these new ideas is really exciting to me. And part of the job, I think, for all of us is to figure out how we can bring these ideas to our patients. So that's kind of what I'll focus on. These are my disclosures. And of course, we've already heard that there is this connection. There's a coincidence between these diseases, and I think this is something we've seen and is really important. Obviously, for a patient suffering from both, it sort of doubles the stress. It doubles the burden of disease on these people. They're already dealing with one atopic problem. Now they have a secondary piece as well. So that makes a treatment conundrum, but it also opens the door potentially for treatments that can kill two birds with one stone, or the more pet-friendly phrase is to feed two birds with one scone. I like that. It's a little nicer, friendlier. We're going to feed the birds, not kill them, right? That's what we're trying to do. So we know also that, I like this piece, that there's a correlation between the severity of both diseases as well. It's kind of fascinating to see. The more severe the atopic dermatitis, the more severe they are likely to have the alopecia areata as measured by the SALT score and the EASI score. So there's something even on the individual basis to some degree. Obviously, these are imperfect, but this tells us that there's really a lot to this, not just on a population status. And we saw this one. This is from one of Dr. Gutman's papers. The immune system is active in both of these conditions, and I think for a long time we thought they were fairly separate or different parts, but now we see there's quite a bit of overlap, and we start to see some of the usual suspects, especially as we zoom out and get a more broad understanding of the different aspects of immunology involved in both of these conditions. Of course, the one nearest and dearest to my heart is atopic dermatitis, and we know how complex that has gotten. We understand how many different pieces of the puzzle there are, and this is very exciting as a clinician because it means each possible thing that we learn about gives us another potential point that we can push back. And I call this the virtuous cycle of drug development, that we learn more about a condition, that in turn gets us new treatments. Those treatments teach us more about the disease, and we keep building upward, upward, and onward and upward. And we're starting to finally see that critical mass taking place with atopic dermatitis and now with alopecia areata. And again, I think we saw a slide very similar to this, if not this same slide, understanding that some of the same parts of the immune system are involved. And we can see, of course, we know the JAK-STAT pathway is involved in both of these diseases, and that's critical. And of course, we know we can treat both of these with JAK inhibitors, but maybe some of the more targeted cytokine-based treatments also may have an effect, as we've already heard about dupilumab, and potentially we'll start to see some of these for the other IL-13s as well. Tralokinumab, lebrikizumab, we have that. And then who knows beyond that, it's possible that some of the other agents that are coming may also play a role. So when we look at this, the other piece that I'm fascinated by is not just the inflammatory portion of it, because that is fascinating, but it's the neurogenic component, the nerves. And when I was in college, I studied neurobiology and thought I was going to be a neurologist, but I quickly lost interest because I felt like we didn't have any therapy. I was so depressed in my rotation on neurology. Everybody was just miserable, and it was interesting to make the diagnosis, and the neurologists were obsessed with this, but then I'm like, okay, what do we do? How do we help? And they're like, oh yeah, we don't do anything. It's a stroke patient. And I was like, oh my goodness. And then I did my dermatology rotation, and I thought, this is incredible. We have so many different ways to approach therapy. We use the elements. We use hot and cold. We use light. We use all these topical agents in different vehicles, an incredible array of vehicles that we can use. We use systemic treatments. We use biologics. Like, it's incredible. But the nerves, they stayed with me. I'm fascinated by this. So we know there's some component of neurogenic inflammation. And recently, in the world of atopic dermatitis, we have one of our first new agents that allows us to sort of more directly address this itch pathway and the nervous system pathway with anti-IL-31. So kind of fascinating to see all of this developing and how this is getting more and more interesting as we go. So several years ago, about 6 years ago now, with Vivian Shi, we put together this little paper because we were reading these articles where people were saying their alopecia areata got worse while they were on dupilumab, other people saying their alopecia areata got better while they were on dupilumab, and we were like, what do we make of this? And we had both had patients. In my experience, most of them got better, but some did seem to have a flare-up, especially in the beginning. And there may be something about that stressful event or just starting a new medicine. So we kind of concluded in our experience treating atopic dermatitis patients, we've seen a temporal association between dupilumab initiation and hair loss clinically resembling alopecia areata, as well as a resolution or significant improvement in pre-existing AA after starting dupilumab. These conflicting clinical observations are mirrored in a number of recent reports. Our literature review revealed 6 recent reports that showed these differences. So it was kind of fascinating to see early on, and this was back in 2019. Now I think we understand much more that this is connected, and for many patients, as Dr. Gutman has really fleshed out, and others, that it seems to be if they have that high atopy, they're more likely to respond, which is really neat. So that brings us to the treatments. When we look at our therapeutic armamentarium, this is for pediatric alopecia areata, which up until very recently we had essentially nothing that was truly FDA approved or studied, particularly in the pediatric domain, let alone in that group. But we now have a number of different things that we can think about, and we start to notice as we zoom in an awful lot of overlap with what we're talking about in the world of atopic dermatitis. So increasingly we're seeing some of the players like topical ruxolitinib, delgocitinib, dupilumab as things that potentially can cross different disease states, and that's really important to us. And then that makes us think, well, what about the future pipeline? What are we looking at in the pipeline of atopic dermatitis? And again, we have some pretty exciting stuff coming down the pike, even though, admittedly, we're in already a wonderful time, a golden age, so to speak, of atopic dermatitis treatments. We have more coming. So some new topicals that are coming. And of course, one of the big areas are the topical JAK inhibitors. That's been exciting. Topical ruxolitinib is an important part now, I think, of my therapeutic armamentarium for atopic dermatitis. Delgocitinib is being studied right now, and I think it will get approved in the United States. It's approved in other markets already, and there's even others that are in earlier stages. So far, those have been a little bit disappointing, though, for alopecia areata, right? So we know topical tofacitinib had this signal early on. It might help. It could potentially be something we could use for patients where we're not able to use a systemic agent, so lots of case reports, and I still maintain some hope that maybe there's a formulation of this that might be helpful. We know that topical ruxolitinib, though, did not pass muster. When it was studied, it really wasn't quite able to show us that it was able to help these patients with enough of an effect to make it get through. But it's kind of fascinating, and one wonders, are there other things we could do to enhance the absorption? Delgocitinib also has some case reports that it may be helpful, and this is a series where they looked at patients that also had concomitant vitiligo, sort of the other one we haven't quite mentioned, but we know is also closely associated, particularly with alopecia areata. Many patients have leukotrichia, and we'll see this combination of things, so that might be also in our larger discussion coming up maybe next year at IEC. We'll also expand to vitiligo because there's definitely an overlap there as well, and here they were able to show that, but other studies haven't seen seen that. So it's fascinating. Here's another case report where they were able to see partial hair regrowth with topical delgocitinib, which is a pan-JAK inhibitor, a topical one that I think will get approved for chronic hand eczema, if depending on what the FDA does. But then looking at this study, and this is again Dr. Paller and Dr. Gutman on this paper. This is their paper where they were able to show it was not effective in moderate to severe alopecia areata. And the speculation here, which seems right, is that it maybe just can't penetrate down deep enough to get to that follicle. So it's possibly the right kind of drug, but the wrong sort of vehicle, the wrong sort of excipients. And I just wonder, is there some way we could pair it with something? Perhaps a laser treatment. Perhaps I've always fantasized about the microneedle technology. They had these special microneedles that you could put on the skin and then peel off, and they didn't hurt. So I wondered, what if there's a way to do something like this? And then that opens the door to some of the newer therapies. So one of the most recent additions for atopic dermatitis treatment is, of course, topical tapinarof, an aryl hydrocarbon receptor agonist, this modulation of that receptor that we think about as something like coal tar historically, but now we have something much more targeted. And again, this is one of Dr. Paller's papers with a nice figure showing us how PDE4 similarly is in this pathway. So we have two new drugs, topicals, that are fantastic, our PDE4 with topical roflumilast, and then our aryl hydrocarbon receptor modulator. So both of these, I think, are fascinating new topical agents that have potential for this disease, although again, it may be that they're stuck and not able to penetrate down to the follicle. Certainly, we're going to be trying it because many patients have overlap. So it's sort of a natural place. You're not even using them off label, but we'll get results from patients who tell us, yes, I was putting these on my face, because that's many of the places where we're using the nonsteroidal agents for patients with atopic dermatitis, and many of them will be putting it in their hairline as well. So I think it'll be fascinating to see the natural history and how this goes. When we look at some of the biologic agents and the small molecules, we know, again, there's a lot of overlap here. Again, we said specifically with the JAK inhibitors, we understand that, but even with our small molecules. So the question will be now, do lebrikizumab and tralokinumab also show an effect for alopecia areata, as we've seen with dupilumab? And will it also be in those patients with a high IgE or with other concomitant atopy? My guess is yes, but maybe not. They all work slightly differently. And of course, we know dupilumab has the IL-4 aspect, which may or may not be a key player in this particular scenario. And I think we just don't know until we really test it. This is truly going to the horse's mouth. We have to count and see what's going to happen. Now, one thing that hasn't come up yet today that I'm fascinated by is the role of the microbiome. And there is increasing discussion about how the microbiome is not just directly playing a role in these diseases, but also indirectly. Some of the drugs are interfacing with the microbiome, and we've even seen this in the cancer literature. Depending on the health of the microbiome, cancer drug outcomes can be dramatically different. So same drug, same cancer. Bad microbiome, drug doesn't work. Good microbiome, drug works. This is big. This changes a lot of things. I think this is one of those weird hidden variables. And my fantasy that I go back to a lot is all the medicines we've thrown away. We said, oh, it didn't pass muster, we threw it away, to go through those trash bins and say, wait a minute, this drug might actually work, but you were not paying attention to this variable, and maybe this is one of those hidden variables, the microbiome. So this was a remarkable paper. Now, this is very small, and I don't want to overdo it on this. I don't want to look too much into this, but they were showing that dupilumab helps shift the microbiome in patients with atopic dermatitis towards a more healthy, more diverse flora pattern. And this is independent of disease improvement. And they compared it to cyclosporin. So when I first read this, my expectation was quickly to dismiss this paper. I thought, well, yes, if you get them better and you heal the skin barrier and you cool the inflammation and break the cycle, of course the microbiome is going to get better, right? No, it turns out in the cyclosporin patients, even when they actually controlled for that level of improvement, they still didn't get the same level of microbiome healing. So this is, again, provocative. I wouldn't put all my money on this yet because maybe this won't bear out in other studies, but I'm fascinated by this. And as I talk to other companies, I say, can we look at this for different medicines? I think this is going to be interesting to see, because something I took for granted that the microbiome would heal is maybe not the case. So kind of fascinating to think about this. Now, what does that have to do with alopecia areata? Well, maybe there is something to this as well. The gut microbiome is really important, and it's one of the ways that we maintain inflammation, homeostasis, and balance in the body. So if that gets wonky, and I'm particularly fascinated by the work of Jesme Actis, an allergist who talks about this epithelial barrier hypothesis, that there are pollutants, that there are damaging environmental factors, things like isocyanates or emulsifiers, humidifiers, microplastics, all these different things that damage our epithelia, skin, gut, respiratory. When you do this, you get translocation of abnormal bacteria, which drives inflammation in the body. So again, we have a compelling story for the fact that this may be a little bit more than we've thought before. So I'm excited about that. And then bringing it back home, if there is this neurogenic component to the itch and inflammation in atopic dermatitis, which I think we know, we all agree, could there be a neurogenic inflammatory component in alopecia areata as well? I think there could be. We definitely know stress can be a driving factor for this, so why not? Is it possible that blocking the nerve response would have an effect as well? And all I can say is maybe. I wouldn't rule it out, not out of hand. So it'll be fascinating, again, as we get these overlap patients, just as we have with dupilumab, as we start with nemolizumab, will we see patients saying, my alopecia areata is better? That's kind of fascinating. And then, of course, the final frontier, at least in the short term, in this more narrow horizon, is thinking about the OX40 drugs. And we have, of course, 3 of them, at least 3 that I'm aware of, that are in development. And these are all fascinating and have a very different approach to the immune system. I think the promise here, at least again, is kind of a, I don't want to say dumb, but a simple clinician, is thinking about them as more having the potential for disease modulation. I'm fascinated by, can we modify the disease process? Can we change it? And this seems like a real potential pathway to do that. So what will happen in alopecia areata? Will we see something? We're going to affect the T cells more directly. Is it not possible that we will see these things change on a deep level? I can't wait, and I'm here for it. So thank you so much for your attention. I really appreciate it.
So I know the schedule says that Natasha will be speaking now, but we'll make a small switch because Natasha is on her way. You know, the distances here are huge. So Amy Paller will be the next speaker. I'm really excited about that. So we'll start actually with new developments in children, and only after that we'll go to adults. So I think Amy Paller doesn't need any introduction, but she definitely deserves one. So she is one of the premier pediatric dermatologists, very known for atopic dermatitis, but also very known in general for pediatric dermatitis, for pediatric dermatology. And she, together with me, was the founder of the International Eczema Council, and super excited that she can come and talk to us about new developments in alopecia areata in children. And she is my partner in crime also in the NIH study, and she will show you a picture from that study. And the study is just enrolling. We are about only 6 months into the study.
Okay, great. All right, so we're going to take a whirlwind tour here. I'm going to skip over kind of quickly where I've heard that there's already been overlap, so we'll get through this more quickly. My conflicts of interest. So pediatric alopecia areata, well, it's been said that 40% begin before 20 years of age, and the prevalence is pretty high. In this one study that came out a few years back, 0.1% of children and adolescents. And then if we look at this slightly newer study, again, about the same 0.13% in prevalence in children, which is actually not too dissimilar from what we see in adults. I think if you look, though, based on age, you can see that this breaks it out, and the red being the lowest line here in all of them. This is the 0 to 5 year group. And then if we go up to the 6 to 11-year-old group, and then even more in the 12 to 17-year-old group, so greater as we go up in age. You can see also that there's a greater prevalence in females versus males as well. Now, I also want to emphasize that in children, it's no different from adults. We see the same range. We can have milder disease where we have just patchy involvement, often covered by the hair itself. We can get into severe disease where we're talking about 50% or more, but less than 100%, and then very severe. And I'm sure you've heard this all already. Now, data from the National Alopecia Areata Registry from just a few years back was a self-reported survey and showed some of the same characteristics. So more in females than in boys, but in that study showed greater severity in boys. Maybe that's also because it's more noticeable. Interestingly, 17% had a first degree relative with alopecia areata. And I will say that this was a study that was skewed towards more severe patients because obviously it was sent out to membership, but still 71% had greater than 50% hair loss there and about 46% total scalp hair loss. 57%, though, in that study had only one episode of hair loss. And I thought that was interesting. How many patients do we see who come in and then we don't hear from them again? So we have a somewhat skewed view from our own practice, probably, of our pediatric patients. A newer study that just came out refuted a little bit that the very, very young children may have more aggressive disease, showing that children less than 4 years of age may have a better outcome than older children. But in general, pediatric alopecia areata has been thought to be more aggressive and more recurrent than in adults. Now, we can't talk about pediatric alopecia areata without saying a word about the impact of it. And in various studies, it's been shown that there's a negative impact on self-esteem in the majority of children. And 60% in one study experienced teasing or other components of bullying. So that really makes it important for us to be able to do something that's going to help these children, because we know what goes on when they're in this very important period of psychosocial development, lives with them for their entire life. There's reduced quality of life, a moderate impact shown in the Children's Dermatology Life Quality Index. And the children say that in particular they experience embarrassment and self-consciousness. But it's not just the child. Here we always have to think about the family as well. And in studies it's been shown that there's parental depression, there's parental anxiety, and in one study, especially parental sadness. There's also a higher prevalence of psychiatric comorbidities, depression, anxiety, and adjustment disorders in children compared to the general pediatric population. So what about the question of the association with atopy? I think we're all convinced of this, but in a study that came out a few years back that I mentioned before, that survey study, almost 33% of children in the registry had a history or concurrent atopic dermatitis. That's less than what was in my straw poll, where I saw the majority of my patients actually told me about a history of atopic dermatitis or currently had the disease. And then, of course, other forms of atopy, whether we're talking about asthma, allergic rhinitis, other allergies, were also noted in patients with alopecia areata. This is from Taiwan, an insurance database that just came out showing the prevalence overall with atopy was 0.37% versus 0.1% in the general population. We heard these same numbers earlier when we talked about the prevalence of alopecia areata. So telling us, again, more prevalent in those with atopy. And almost tenfold higher risk overall has been shown with, in this particular study, food allergy being the most significant predictor. And one other study I want to mention of the early onset alopecia areata in children, that having atopic dermatitis, which occurred in about 20%, was the only factor associated with a poorer prognosis. So what about biomarkers? We've thought a lot about biomarkers for atopic dermatitis, certainly, and do we have them for alopecia areata in children? And I would say this is an area that really needs more investigation, but there have been a few things that have come out that I will show you. One is a study that just came out from Sebald's group in Toronto, in which they had 10 healthy controls, 10 who were 6 years and older with alopecia areata having a SALT score of at least 30, and 10 who had that as well as atopic dermatitis, but not the most severe. And none of these patients were on systemic therapy for at least 3 months. What this group found is that in those who had alopecia areata, the mean serum TARC and IL-4 levels were greater than in controls. Interestingly, those who had alopecia areata alone had higher levels than in those with the numerically than those with alopecia areata plus atopic dermatitis. Not statistically significant difference, but unfortunately one problem with this particular study is that there was no accounting for other forms of atopy. It was strictly patients with atopic dermatitis. So I think we do need to look further at whether there are blood biomarkers that are different between those who have alopecia areata without any atopy versus those who have alopecia areata plus atopy. There's actually also been a study that actually looked at biopsied scalp from children. And this was children mean age of 10 years with high IgE levels compared to adults with and without high IgE levels, but with alopecia areata, altogether 28. And you can see, looking at the principal component analysis here on the left, that there were differences between the pediatric healthy control shown in blue and the pediatric alopecia areata with the high levels of IgE shown in gray towards the right. There was, though, overlap with the adult alopecia areata, and similarly, the adult alopecia areata did not overlap with the healthy controls. But very importantly, when you look at the pediatric alopecia areata versus normal control shown in green here, and the adult alopecia areata versus those with normal control shown in red, you'll see much bigger circles of upregulated and downregulated genes in the pediatric group. And a further dive showed that their sharing of the increased particular type 1 immunity as well as CD8 positive infiltrates, but a much, much more robust and diversified immune response in the children. So how do we treat alopecia areata in children? And Peter showed you a little bit about some of the guidelines that we've used in the past and how those are starting to move forward. This was a survey of 53 pediatric dermatologists that was published in 2023, so conducted before that in 2022. And at that point, we're mostly treating first line with class 1 or class 2 topical steroids, potent steroids, regardless of age, and then we're using intralesional triamcinolone most commonly second line, and of course, largely in your older adolescents. But if we go to those who had greater than 25% scalp involvement, we use less of the topical steroids, and we use more of oral steroids and immunotherapy like squaric acid dibutyl ester. Among the oral medications, the group used methotrexate most often, but still using systemic steroids and at that time off-label JAK inhibitors in about a fourth of the patients. Now, caveats. First of all, nothing was out yet that was approved for children. Ritlecitinib is now on label for adolescents starting in June of 2023, and most actually now are using oral low-dose minoxidil. We used to throw in topical minoxidil. I haven't used topical minoxidil except in a rare patient in the last few years because of switching to the oral low dose. And I've used it as low as 2 years of age in patients with absolutely no problems with it at all, other than some patients who get too much of the hair from the oral minoxidil. And for some reason, when they have alopecia, they don't seem to mind that. Very few of them have wanted to stop it when that happens. There was a European expert consensus statement coming out that suggested the use of oral minoxidil with weight-based dosing. And like I said, in our practice, we haven't really seen any problems. Well, let's go back to the use of corticosteroids. How are we using that in pediatric dermatology? Well, in general, we try to avoid it, of course, but there have been now a systematic review that came out last year that showed 5 studies of IV and 3 studies of oral pulsed corticosteroid. And as you know, it seems that in adults, dexamethasone oral pulse, which is more long-acting than other steroids, tends to be used increasingly. So we've had some experience with this with children. Overall, with this pulsed corticosteroid, in the systematic review, 56% had at least 50% hair regrowth with a mean duration of 12 months. What they found is the ones with the best and the longest duration of responses were the less severe cases, more recent onset, and the greater numbers of cycles. Nothing very surprising there. What's been my experience? Well, like I said, You know, we pediatric dermatologists recoil about the use of systemic steroids, but I do use them sometimes. You know, when those patients call you and they've been doing well and then they're having that shedding again, they're losing their hair, is there a role? Well, we need more studies of that, particularly in children, but I do use some of the pulsed regimen of the dexamethasone, and these have been used. Occasionally I will couple use with methotrexate initiation. I don't like to go more than 8 weeks, occasionally 12 weeks, and I have seen benefit with it, but the problem that I see in kids is weight gain. Some have become Cushingoid on this regimen. I think we have to be very careful about that. And then again, I will say that one of my problems with using, as we talked about a minute ago, these class 1, class 2 corticosteroids, and particularly under occlusion, which is sometimes done, is that I've also seen what look like systemic steroid effects, including becoming Cushingoid from this use. I also want to reiterate what Peter said earlier about the fact that these topical agents don't seem to do it. I don't think we know what we're doing with some of these, even potent topical corticosteroids, but the results are far different from when we inject with the intralesional steroid, and we know we're getting it to the base of the follicle where the action's taking place. So I've backed off more on the use of these topical medications because I'm a little worried about the effects they may be having, but not confident enough that they're actually doing something. So what about methotrexate? Well, I do use a decent amount of this for kids, and especially for younger kids. This is a pooled analysis of 76 published cases of pediatric atopic alopecia areata who failed on other therapies. They were dosed at a mean of 0.4 milligram per kilogram per week, pretty much what we do for any other disease. And in some cases, they were continued on squaric acid dibutyl ester. In other cases, they were continued for 1 month on oral corticosteroids. And in this pooled analysis, there was a mean of 4.2 months treatment to first regrowth, and altogether about 50% experienced success with more than 50% regrowth, and an example of this is shown here. Importantly, there were some adverse events, just as you might expect with methotrexate. GI were there, fatigue was there, some dizziness, but no laboratory analyses in anybody in this group. And 30% recurrences on therapy. I've seen the same thing. My experience is that if I can't get something else, then those with more than 50% loss, I will offer this, always combined with oral minoxidil. Here's an example, because this is an interesting case. This was a young girl who I started at 4 years of age on the minoxidil. She had alopecia universalis, and over that 4-year period, she was getting a fair amount of her hair back. You know, we always worry when it's partial like this, right? Because they still have these areas, and she was wearing a wig. And one day she came in, and her parents said, she wants to get the injectable methotrexate. And I said, really? I've never heard a child ask for that. Well, it turns out her brother had rheumatoid arthritis, was getting a biologic. She wanted to be like her brother. We switched her to the injectable methotrexate, and her hair, which hadn't really been coming in for a while, suddenly started coming in. So just something to think about if you use methotrexate. We like the oral because it's not injected, but sometimes patients do respond. They probably have some better absorption. All right, what about off-label JAK inhibitors? Pooled data in 42 children less than 12 years of age from 9 studies before 2023 showed that 81% had at least 50% hair growth on the dosing, weight-based dosing, 2.5 to 5 milligrams daily or BID. And very few, one a side effect. One had a headache, one had elevated liver functions. A review of 36 children and adolescents with a SALT greater than 20, and 36% with total alopecia, 56% previously on systemic steroids, with at least 6 months of tofacitinib. 72% reached a SALT of 75, mean of 4 months, and 53% a SALT 100. So really good experience with them. That was our initial introduction with kids off-label and when we could get this drug. I would say that very few experienced adverse events and only 2 discontinued. This is just an example of my own experience with this. I've had several kids on this. This is a boy. You can look at the dates and see how fast Now, this is combined with minoxidil. I always add the minoxidil. How fast he's getting his hair back. So over a 4-month period, he pretty much all came in. And I love the frosted color that some of these kids get. I think that's so fascinating, suggesting that the attack on the follicles also killing off some of the melanocytes, and that you're seeing this look. Over time, of course, that disappears. So this is a boy who had to be dragged into the barber because he loved his hair so much that he didn't want to get it cut, but he did get it cut, and when riddlesidenib came out, he was able to change to that. And what about riddlesidenib? Well, this has been approved, as you know, for a while, and I'm just going to talk here about the adolescent data because it's all we know is of the 105 adolescents that there was here a dose-dependent response with the best at the approved dosing, 33% achieving salt less than 24 weeks of the 50 milligrams daily. And here we have the same kind of side effects that we've seen in the adults, particularly headache, acne, and nasopharyngitis, with really very little in the way of anything we'd be concerned about, and none of the boxed warnings that are associated with JAK inhibitors. This is my representative experience, just going to show you one girl who, when she became 12, we moved her on it. She'd had a past history of courses of oral corticosteroid, failed the immunotherapy, put her on my usual dosing. Her eyebrows started to grow a few months later, sparse hair at the occiput, some early acne. By just a few months later, she really had pretty much her full head of hair, still had the acne, but we're working on that, not a big problem, and here she is another few months beyond that. So really good results in the vast majority. I've had some with partial, but most of my patients have actually had total, and no one has had any issues. What about pre-adolescents? Well, there is a phase 1 open label study, and just showing you that the results look good there, but of course very small numbers of children with a 20 milligram dosing daily. Future directions, I want to, of course, emphasize that baricitinib is not available in the United States in children. It is available for atopic dermatitis, another overlap, for those who are 2 and above, and has been used quite a bit there. And the results look good for that as well. 10 children here with severe alopecia areata, 4 with concomitant atopy, and here we can see 9 out of 10 were responders with a mean SALT reduction at 3 months of 60. And then only 1 who had an adverse event, which was transient neutropenia. One non-responder, interestingly, with atopy had a SALT 100 at the beginning and was switched over to dupilumab, and 7 months later was down to a SALT of 15. The trials are now ongoing with baricitinib, and there will be a late-breaking abstract at this meeting I saw of the results in adolescents. Okay, so every single JAK inhibitor, there are anecdotal reports out about. Here's my anecdotal response, just showing you, for example, to upadacitinib, a child who was in a trial for atopic dermatitis. Riddlesitinib's in pre-adolescent studies now, an adolescent adult real-world study. Upadacitinib's now in trials as well in adolescents and adults, and duruxolitinib also in studies in adolescents. But I really want to end with the experience with dupilumab. You heard a little bit already about this for Emma, so I'm going to just quickly remind you about this real-world study that her group actually presented with the mean SALT of 20.4 at 48 weeks and 2.2 through 72 weeks, correlating strongly with the baseline IgE, but negatively with the baseline SALT scores. There's also been a scoping review of 31 patients, 77% hair regrowth, with a mean reduction in SALT of 42 in a mean of 3 months. So I don't know if it's going to be that fast, but it doesn't matter because this is such a safe drug. I think it's going to be very exciting. This is just showing you from that study I showed you from Emma's group, some of the amazing results that we see with the dupilumab in this group of patients. You heard about the ongoing NIH-sponsored study that's going to enroll 76 patients. We're really well on the way towards that now, getting very close to that number, with an open-label extension for 48 weeks after the double-blind period of 48 weeks, and we'll see what happens in these children. But I want to just show you, this is one of the results already. Emma got started first and is able to show here, she kindly gave me this picture at 32 weeks out in this person who, as you can see, at baseline, has almost near total alopecia, and look at 32 weeks. So very exciting data. But I want to say that given the safety in young children, this is something we should be thinking about for younger children as well, off-label. I'll just show you this patient, 2 years old. I knew she wasn't going to be able to be in the study, so was able to get some dupilumab to try for her with alopecia universalis. Started it with the minoxidil. In this case, 3 months you could see the peach fuzz coming out, 4 months, 8 months, and she is a pretty happy 11-month-old who doesn't have all of her hair back, but mom says it's now coming in the back as well, so we're pretty excited about that. And I think I'm going to just stop there and thank you for your attention. Do we have any time for questions, or we do that later?
So we did it a little bit backwards, but now we are super excited to hear from Natasha, my co-chair, on new developments in alopecia areata for adults. And who is better than Natasha to tell the story?
Which one is me?
It says 01.
I guess, because we updated it.
That should be it.
It was a 7 when I uploaded it, but it's fine. Okay. Hi, everybody. Thank you so much for putting up with me. I have all sorts of conflicts because my whole life is alopecia areata. This is what I'm going to start talking about. There's an article that came out. For many of you may have seen it, but some may have not. And it was in JID, and it said reduced mortality rate in patients with vitiligo compared to people that do not have vitiligo. This was a large study that was done in Korea from a database, and it made me think. I'm like, well, if this autoimmune condition has survival advantages, what does alopecia areata do, right? Because things tend to run kind of together. Another new study that just got published in December, this was a group from Asia that did look at 17 most common cancers and alopecia areata, and they were trying to see if there is an increased risk, but actually showed in GWAS studies that alopecia areata can be protective for hepatic bile duct cancer, which you can be like, okay, that's some rare stuff, Natasha, who cares? But the other thing is this, which is plaguing us, particularly where I live in California, 30 and 40-year-olds. So interesting. So I'm like, all right, so let's look at it. There's this huge worldwide, like 3 million plus people database called TriNet X. And I asked people last year, one of them was a bioinformatics, one of my fellows. I was like, can you see if alopecia areata have this advantage? So he gave me these numbers. We're like, look at the numbers versus the match control. It's like half. I'm like, no. I'm like, do it again, because it's like a live database. I'm like, send it to statistics. So bottom line is this is published in a small letter in JAD, but I really want to know if there's something to this for people that know how to do this. And I want to know, does alopecia areata give some sort of a survival advantage and that autoimmunity? So then let's talk about the treatments. Should we treat, right? Yes, we are going to treat. But this is why I'm going to bring up some of the medications that we're using and where are some of the directions where we're moving. Classically, we think of alopecia areata as a T-cell condition. We are knowing more and more about the T-cells that we're combating, but we also have an understanding of other players that are getting involved. Maybe these are minute things, but I think it's many different ways to get to one disease, one alopecia areata, or one condition. So this is good for us because if something doesn't work for one person, maybe something else will. So let's talk about the success of JAK inhibitors because I think they've changed the world for alopecia areata. I know that 10 years ago, when I was part of National Alopecia Areata Foundation, it was our dream to be where we are today. And I get teary-eyed sometimes because I'm a softie, but to have like the medications that we have right now available on the market and to really have 3 approved, it's a miracle. So what do we know? We know that they work. We know the safety is very closely monitored because the FDA is very tough on JAK inhibitors. They're well tolerated by patients. Day-to-day, not much drama. We do worry about the long-term effects, and we'll talk about it. And they do cost a lot of money. So right now, you better have a PPO or a rich cousin, somebody to get it for you. The pictures we get all over are this. These are people from my trials, and I don't have access to the original ones because they're part of the clinical trials, but these were damn near totalis, and this is what they look like. So we give people the promise of this beautiful hair. But this is the reality, but with some caveats. What is the beauty of JAK inhibitors and why so many new come? because there are 4 enzymes in this family, 1, 2, 3, and this sheep of TYK2. But the point is we have ways to block, because these things work together, to kind of get different combinations to unlock the key to treat the alopecia areata. So right now, what are the things that are approved for alopecia areata? We have baricitinib, which is a JAK1, JAK2. It's a once daily pill, comes in 2 doses, 2 milligrams and 4 milligrams. On label, you're supposed to use the higher dose only for totality universalis. In real life, we're pretty much putting most people on 4 milligrams unless any kind of issues. Ritlecitinib is a JAK3 and a TEC inhibitor. As a whole family that we don't know much what they do in alopecia areata. It's only 1 dose and it's only one thing. And I like to show the pictures so people get a sense that it's a capsule, so they can't like break it or do anything with it. Duroxolitinib is also a JAK1, JAK2. It's a twice daily pill. So they do have some claims that are different than the others, and I'll show you some stuff. I don't know what the pill looks like because right now there's some logistics issues as to what's going to happen with its kind of availability. I'm going to show you I hate boring slides, but this is just slides that I'm going to put a square to show you that at 24 weeks, whether you're looking at baricitinib and the success of the medication. So the higher doses, you can see where the things are. This is ritlecitinib, so just look at the higher one, and this is duroxolitinib. Pretty much all of these medications are kind of par to par. So when people are like, what's your favorite? Which one works better? Because there's things on social media, there's some preconceived notions. It's all really nuances, and it's going to really come to terms. We have to come to terms of what works better and for what. So this is, when you look worldwide, really most people have been on tofacitinib and are treated with tofacitinib worldwide for alopecia areata. These are the other ones that are now being studied or are in trials, phase 3, et cetera. How they work and how they're not work, we're going to find out soon. This is a thing that I really hope will also get approved for alopecia areata. We do have clinical trials, but I do prescribe it in clinic, especially because it's approved in 12 years and above. And why is that important? Because it's atopic dermatitis. So for our patients that have atopic dermatitis and upadacitinib, and if they haven't responded to other things we've tried, this is also an option. So why do we need more, and why do we need other medications? We have JAK inhibitors, so aren't we done? Shouldn't we just stop here? Well, the way we know from the stuff that is available now and from the data we have, we're supposed to give these things for as long as we shall live. Kind of like think about like insulin with like diabetes type 1. The current dogma is that we should not stop treatment because when you stop treatment, stuff falls out. And the other problem is that not everybody responds, particularly our severe patients, the ones that need it, and people whose episode is longer than 4 years, kind of teaching us to have to move the needle and treat people early and not wait for imaginary algorithms that don't exist. So the other thing that really we still have to, as providers, get over and then collect more data is that they have a boxed warning. And the boxed warning is for infections, malignancies, cardiac event, and thrombosis. And the thing is, it's not, as I said, day to day, people don't really feel these meds. But what happens 10 years down the line if I give them to a 15-year-old, right? What happens 20 years down the line? I don't want to be responsible, so we're collecting data. So far, nothing scary. So if you look at baricitinib for serious adverse reactions, I sit down across the patients and I look at these numbers. And the serious infections was during COVID. There was nothing really scary. Opportunistic infections, which is something we saw with our biologics, kind of like things you get with HIV, et cetera, we really don't see any. But if you look at all the other scary stuff, the malignancies, the cancers, the cardiac, and the DVT, I look at the patient and I say, you can count everything we've had thus far in all the trials on one hand. So everything is single digit. So as things go, as things develop, as we're collecting more data, we'll get more and more things. And everybody will say that all these box warnings are because of rheumatoid arthritis patients. And rheumatoid arthritis patients are really like older, sicker than alopecia areata. But using the same TriNet X database, we actually found out that most of the things still hold true. They still kind of have the same things. One thing that RA patients had a lot more was urinary tract infections and thromboemboli. So hopefully our AA patients are not as prominent with a thromboemboli effect. On a day-to-day basis, from the data across all of them, but this is the baricitinib reflecting it all, upper respiratory infections, kind of like colds, headaches, and then acne, particularly in young people, are the most common side effects. From infections, it's herpes zoster, so shingles, is something that we do definitely see, and this is common for the whole family. So who do I avoid stuff in? I avoid this if people have a prior venous thromboembolism, but I'm going to tell you that right now I have 2 people because their hematologist signed off and they said they're on whatever Equalis is called. But anyways, malignancy. I have people with melanoma in situ and this breast dysplasia that are coming through. So real life is really challenging everything. I have people that have shunts in their brain, so people with end-stage kidney disease, so things get a little bit complicated. The other thing is really, why do we need other things outside of JAK inhibitors? They're not allowed during pregnancies, and a lot of patients are young, and we have to think about what we're going to do with these women, because you don't want to treat somebody, get all their hair back, then they get pregnant, they got to stop the medicine, and then they lose it all. It's just not fun. That chase is not fun for patients. So you have to have a conversation about it. You have to know what they're planning, because you really don't want to put people on a roller coaster. What we know, they're not allowed, but when it comes to organogenesis data, the drug does cross the placenta, it's teratogenic, and there's issues with it. So far, nothing when you look at things, but this is the data. These are the facts. So this is where we're at. The only one is deucravacitinib, but that one hasn't really still been shown for anything, and definitely is not approved for AA. And the other thing why we need new stuff is we need stuff for kids less than 12 years old, and you heard Dr. Paller. And this is where it brings me. Treat the atopy, treat the alopecia areata, particularly for kids. Why do I say this? There's this whole concept of atopic march, right? Like march. And we never really tied these things together, and I think that's why still a lot of people are pushing back on this. And when you talk about atopic dermatitis and alopecia areata, it's not for every patient. It's for people that have these things together. But in children, it's definitely, what did you say, like 50, 60% almost? In adults, it's definitely 30%. So if you can address something, by all means, we really should. This slide I will never take out from my presentation just to show it, because nobody really talks about it. It is number one, and that's why we have to put it in. Everybody checks thyroid, but we shouldn't. Well, we should, but we shouldn't really worry about it as much. Study of alopecia areata in children with their serum biomarkers that just came out actually showed that they tested kids that had atopic dermatitis and they didn't, and they showed that all had elevated immunobiomarkers, but the ones with AD especially had higher Th2 cytokines, just to show you kind of the variety even amongst the kids. And to, again, talk about this. As we're going ahead, it's going to be more and more personalized. And this is why Dr. Berkfeld and all the generations that have taught me, have taught many of us in this room, will give people antihistamines. So things like fexofenadine and cetirizine are still a staple in my office if things are not needed, like if somebody's very low SALT scores. So what do we know about AA and allergies when it comes to the patients? For IL-4 and IL-13 involvement has been described. You heard about it today, and is the role for dupilumab. The dose may have to be higher for dupilumab. Maybe that's why, it's such a slow-working thing. Serum IG biomarker is something that we do check, but Dr. Gutman said not necessarily for everybody now, so now I'm putting people that are not on it. This is from Dr. Britt Kraglow's publication on a pediatric patient with dupilumab, where she talked about taking 6 months or more. Then there's this about IL-13 pathway inhibition stuff, because now we're skewing away from the IL-4, and there's a new case report that came out showing that tralokinumab in a patient with atopic dermatitis also regrew the hair and improved the SALT score. So more things that are available as things go forward. People always will ask me, but I had these reports that he loses hair. And I'm like, well, we dealt with this with the biologics, with TNF alphas. You treat psoriasis, you get other things. You treat your ulcerative colitis with the same medicine, you get psoriasis from dermatitis. So it's not really AA. There's some sebaceous gland atrophy, so we're yet to see what that means. But I do really advocate for IL-4 and IL-13 inhibition, particularly in kids and people that are not candidates for JAK inhibitors. The other thing for novel therapies, things that we're excited about, OX40. These are members of the TNF receptor superfamily, co-stimulatory for T cells, and this is, again, addressing two pathways. We're stealing them for atopic dermatitis to use them in alopecia areata, trying to affect the T cell expansion, differentiation, and the memory and effector T cells. How do they do it? They control inflammation by inhibiting. So we have two ways to develop antibodies, whether they're going to be towards the OX40 or the OX40 ligand. So these are things that are out there now, and then a bunch of them coming out with promising stuff for atopic dermatitis, and we really hope we get more otherwise. Forutostat is something that works definitely differently than everything we've heard before. It blocks production of de novo pyrimidine and DNA replication, so that's exciting stuff. Just a little bit out the ballpark to show you this. A different way to look at things. And then this is kind of fun stuff. It's a multi-cytokine inhibitor. I remember from back in the days in NAF, it was a small startup. They've been purchased, and now they're doing phase 2 trials. So it's a very exciting concept. It's a way to kind of use peptides to target cytokines the way you want them. So you design them. So if antibody works by inhibiting one cytokine, JAK inhibitors by like calming the whole storm, these EQ peptides, you can pick and choose what you want. So for alopecia areata, they picked IL-2, IL-9, and IL-15. This is the way that they work. The 15 and 2 control the CTL, and then IL-9 for mast cell kind of inflammation. So both things almost driven. And this is from phase 2 in adults that they just kind of published online, at least in reports. They didn't show any serious adverse effects, and they did have a pretty significant SALT score. Now, this is an IV medication, so they're working on sub-Q. Hopefully, they develop it so we can all be happier. There's tons of other medications, but we're going to talk about these on Saturday at the AAD. Thank you so much for your attention. Okay, and now we get a 20-minute break.